rule out whatever, and John doesn't. And John and I just had this disagreement about it, and we thought that, hey, look, on the show, we're going to argue about which one's right over another. So I just got on AAE's website, and they have this whole consensus on
and there's a new consensus
CTs.
statement that's out that was just updated literally like a few months ago about when should cone beam CT be used in endodontics. I
just couldn't do it to my boy, man. I just couldn't, even though it'd be
Wes
fun,
sends it over, and I was like, well, there we go. Because what I always felt like was that the question always is it actually proven to increase your ability to properly diagnose? I have no argument that it assists you with treatment, and I never had that argument. I think there's some great, but the question was, did we need it, or was it just something we were doing because it made us feel better? Was it actually going to make our treatment better? And I think this consensus statement kind of just puts that to rest. It says basically that in the posterior part of the mouth, premolars and molars, that CBCT is the imaging modality of choice for pre-operative radiography. So that means that, take a PA. That's great. That's a good start because it helps you to kind of zone in on where you're going. But you should be taking a CT before you do premolar or molar endodontics as the ideal. Now, for anteriors, when there's no problem, you're not worried about anatomy, it's not necessary. But if you have a question about anatomy, or if you have a question about diagnosis, and those were the times I was doing it, was when I had a question about anatomy, or I had a question about diagnosis. But I wasn't doing it routinely for molars.
Right.
I wasn't doing it routinely for premolars. And after reading that and looking at the studies, it's there.
Yeah, let's just rattle off some statistics for you guys. Well, first of all, the question I asked John months ago was like, hey, look, dude, can you honestly say that taking a radiograph, well, just let me get into it, because the thing is that you need to start taking them, all right? And it's just another reason to have access to a cone beam is, primary endodontic lesion detection. With traditional intraoral radiographs, 20% compared to 48% detection. Okay, the resolution is there to detect lesions primarily. CBCT detected 17% more teeth with periapical bone loss than that of conventional radiographs. Studies show that there is a strong correlation between sectioning teeth and CBCT canal detections, meaning like if we took a tooth and we cut it in half looking for 4 canals, 5 canals, that there is a strong correlation between actually physically looking at the histology of the tooth and taking the clinical radiograph. MB2 detection is higher with CBCT than conventional. Higher detection of vertical root fractures. 88% sensitive, 75% specificity. Now, I looked up the difference because I had to go back and look at these little words, and they mean a lot, okay? Whenever we're talking about medical diagnosis, the word test sensitivity means the ability to correctly identify those with disease. That's a true positive. Like, we don't want false positives, we want true positives. So CBCT, true positive vertical root fractures, 88% of the ability to truly give you a positive where there's a vertical root fracture there.
9 out of 10 times you're going to see it.
Right. So then it says, what about specificity? How you say it, John?
Specificity.
Yeah, specificity.
I love it.
Oh, man.
The S word.
So anyway, that S word, yeah. So is the ability of the test to correctly identify those without disease. 3/4 of the time, you're going to be able to say, that's a normal tooth, that's a normal tooth, that's a normal tooth. And then 88% of the time, you're going to be able to say, there's a vertical root fracture, there's a vertical root fracture, and to definitely determine. We could go on and on here.
Yeah.
You definitely need to be taken for retreats. What about that, John? Every single time.
Every single time.
I mean, we could just keep going on and on. You can go look it up for yourself.
Yeah, I think that what I got from this is that, first of all, immediately it says that, if you don't have a CT machine, it gets a little crazy there. Like, should you be doing molars? And I'm not saying you can't do good molars with it, because
and they're not saying that.
They're not saying that. They're just saying it's the imaging of choice. They're saying that it's the best case scenario. You get the most information out of it, and it gives you more than what you get. And I definitely agree with that. But now we're seeing that it's so much better that it really is something that you may want to consider as a reason once again to look at CBCT in your practice if you really want to do endo at the highest level. I just saw a case just last week where I had a young girl, 3 root canals done, 3 missed canals on her teeth, and she came to me with pain on one of them, and she's had now crowns done on these teeth, and all 3 of these teeth are going to need to be retreated just because. And I took a CT. It's clear as day. Clear as day. I mean, these weren't difficult to find. And if you know what you're getting into, it just creates a whole different mindset when you enter a tooth and you know there's 4 canals and you know basically where they are. And, you know, if you don't find that 4th canal, you're not going to finish the case. And it just changes the way you look at it. So it's something to definitely think about. And we probably should just finish up this episode talking a